A very good morning to you, Karibuni Sana. Thank you for being here this morning as we continue with our conversations. Healthy Friday is a conversation that we get into now at this hour because we're going to be looking at a number of things today. A Healthy Friday conversation will be around issues of, contraceptives. And we have issues with that in terms of contraception, what has or has not happened with the drugs that are necessary. Okay, it's going to go into this quite a little bit. But our guest for this hour to help us look through issues around the contraceptive crisis, Dr. Kireki Omanwa is the president of the Kenya Obstetrical Gynecological Society, and he's here with us this morning. Daktari, good morning.
Good morning.
How are you doing?
Niko salama.
Uko salama?
Kabisa.
Karibu.
Mm-hmm.
I know we'll have conversations, but just assure me that you're on my side before we move further. So I'm on your side.
I have to know what the agenda is.
No, I just say, I'm on your side. It costs you nothing, I promise.
But I'm always on your side.
That's all we need. We can move from there. So, before we get into this conversation, Dennis is going to share today's proverb. We'd love to get your interpretation.
No problem.
Now, the side that you need to be in is this side, Daktari.
Yes.
We are in Mali where there is a lot of gold,
Yes.
And this gold has been used over time, including the richest man to ever traverse the continent, Mansa Musa, having used that wealth. And when he went to the Arab countries, Saudi, and came back, he came back with scholars and made Timbuktu to be a center of excellence for Islamic studies.
Correct.
But there is equally that great mosque in Mali that stands out. It's a UNESCO World Heritage. Why? Because of the architecture that was used. They used mud and bricks to build these stunning piece of architecture that many ask, how was it done? Speaks to the ingenuity that Africans themselves have when given an opportunity, right? But let's go to the proverb. Friends are like shoes. You may have many, but you only walk with the ones that feel comfortable.
Friends are like shoes. You may have many, but you only walk in the ones that feel comfortable.
Yes.
I think ladies love shoes in general. So Ndu, I'm on your side.
Now stop it. We know.
So I think my understanding, my interpretation of that beautiful proverb is that in as much as you may have many pairs of shoes, at the beginning, when you have a pair of shoes, there can be different sizes. You need to choose the shoe that actually fits you comfortably. Sometimes they say you need to break into the shoe. You wear it a bit so that it molds, or your foot molds into it. And then thereafter, even if you have many pairs of shoes, there's that pair of shoes which you feel most comfortable in. So I think friends are like that, in that you will have many people who may pretend or will aspire to be your friends. With the time, you'll get to know that with X, I'm okay. I can actually let my hair down, as it were. But with Y, I can go to a certain extent. Even if I'm okay, I'm comfortable. But there are some things which I cannot sort of open up, I cannot discuss with Y, as compared to X. So I think in that respect, we need to know who our friends are, number one. And then also there's a quote that says that, especially men, if you have one good friend, then you count yourself lucky. You count two, then you are blessed. Three, you are an extremely happy person, as it were. So we have that one pair which we really, really like. If you have two, which you also enjoy. If you have three, then you have a very good sort of choice, as it were.
Well interpreted.
Indeed.
Beautifully so.
So I want to give it a little bit of a brief to this contraception crisis that we're talking about. But before we do that, one of your would-be patients, just over the last couple of days, was delivered of her baby on the side of the road. And of course, that's not a contraception issue because we've gone way past contraception by the time we're talking about delivery.
Correct.
What does that speak to from a place where you're practicing as a president of this obstetrical gynecological society? When we see things happening like this, where are we?
First of all, I think that was a very, very sad and bad situation, because pregnancy and childbirth are quote-unquote sacred events, as it were. These ladies, when you bring life to earth, that is actually a sacred event. The only thing is that it happens so often until we have treated it as something which is casual, something that is normal, and so it can happen anywhere and anyhow, which is absolutely wrong. That lady who delivered by the roadside, I understand she was 50 meters away from a health care center, and apparently there's somebody who actually turned her away. That is criminal. That is negligence. Wherever it happened, I think it happened in Kahawa Wendani. Kahawa Wendani is in Kiambu, not in Nairobi. I think the governor should be held accountable for that, because he has health officers, who are supposed to take care of these mothers. If we don't take care of our mothers, who are we going to take care of? That is number one. Number two, pregnancy and labor, in as much as it can be low risk, as it were, it can turn into a high risk, sort of situation. Just like that. What if this lady had started bleeding by the roadside, and then she would have ended up, as a statistic. She starts bleeding. There's nobody to help her, nobody to do any intervention. The public will carry her and rush her to a hospital somewhere. We even don't know where, because she was near a health center. That was not done. And then we talk about reducing our maternal mortality ratios. I think we are not serious as a country. That is number one. Number two, a country is judged by the way it treats its mothers who are delivering. We call ourselves a middle income. I think we recalibrated our status to a middle income country. And if we cannot take care of such straightforward things as a mother delivering with dignity and with respect, I think we have lost the mark. And then thirdly, if this person who turned away this mother, if that was his wife, would he have liked his wife to be treated that way? So there is a lack of humanity, a lack of compassion, and a lack of common sense. This person is a criminal and should be treated as such.
Not mincing words this morning. And it would be interesting to then hear, it's little to add to that, because if it's happened there, it's very possible that it's happening in other areas as well. Maybe
also, if I can make a rejoinder to that, we are having a nurse strike, which is ongoing countrywide. The other day I was on call in Kenyatta, and patients had to be turned away. Some hospitals, they came and they said some hospitals zimefungwa na kifuli. Are we serious as a country? So what happens to these mothers when they come to these hospitals and they're told, hamwezi kuja, hamwezi kuzaa hapa, you have to go? We will have serious consequences in a short while. Our maternal mortality ratios are going to increase. After having come down significantly. Our neonatal mortality ratios are also going to increase. We will have children who are going to have a lot of issues, cerebral palsy, and so on in a short while. So all these are going to actually put more pressure on a health system which is creaking and not functioning the way it should. Maybe again, coming back to that case of this lady who delivered by the roadside. I think His Excellency the President opened or started what is called the ambulance. Ambulance. Yes. I mean, it would have cost this person nothing just to call 922, and there is a network of ambulances which would have actually taken care of this lady. My sincere apologies to this lady. It should not happen that way. We have collapsed as a country, and this is not right. Albeit the fact that we are collecting a lot of taxes, which are supposedly going to healthcare, but we are not there. This is sad. It is a tragedy for our country.
Somewhere else where we're not there, interestingly enough, is on the issue of contraception. That contraception actually does play within the ecosystem of family planning, as well as healthy behavior. Then when it comes to sexual behavior, as well as then later on childbearing. Now, I'll just give you a little bit of a background. Kenya is facing a severe national contraceptive crisis, and it's driven by the fact that there is reduced donor funding. Now, why the contraceptive issue should be dependent on donor is probably another policy conversation. But this is one of the reasons. There's also funding disbursement delays and also chronic public health stockouts, meaning it's just not available on the shelves.
Correct.
Public clinics lack essential supplies like oral pills. There's a story today about the fact that hospitals around the country are lacking medication from KEMSA. KEMSA's got a big bill.
8 billion. I think it was about 8 billion.
8 billion shillings. And in this stockout, contraception is one of them. It's leaving vulnerable women and youth at high risk of unintended pregnancies and sexually transmitted infections. The World Health Organization tells us in a report that we've seen today that gonorrhea and syphilis is going to continue affecting Kenyans well past 2030. This is involved in that as well. Donor funding cuts, the reduction and shifting of support from key international partners like USAID, budget shortfalls out of roughly $22.9 million needed annually for family planning. We're seeing that actual cash disbursements to the Kenya Medical Supplies Authority stalled, not reduced, stalled. Depleted inventories. Public facilities have reporting zero or critically low stocks of short-term methods like combined oral pills and 3-month injectables, as well as male-female condoms and implants. Now, let's take the last one. Let's take the very last one.
The very last one.
Because we're talking about contraception here.
Correct.
And we know that in contraception is a process whereby you avoid pregnancy.
Correct.
Right? And there are certain things that you take. Most taken are by the women in this case. Now, and that's how you help with things like family planning or unwanted pregnancy. Now, if you don't have the contraception, what are we staring at here?
Thank you, first of all, for bringing up this very important topic. It's a topic which cuts across all sectors, as we say. Maybe just a quick overview of what contraception is for those of our viewers or our listeners who may not have a very good idea about what contraception is. As you said, contra and deception is against conception.
Right.
Sometimes we interchange contraception with family planning, which is understandable because we do use contraception to space our family. And August is contraception, family planning or contraception awareness month, which is a good thing. Now, when we talk about contraception, we can broadly divide this into two groups. Number one, we can talk about contraception which is reversible and contraceptions which are irreversible. The ones which are irreversible are, for example, when we cut the tubes of the fallopian tubes of a patient, of a lady, for whatever reason she's had the number of children that she wants to have, or sometimes she doesn't even want to have children at all. Then we and this is the method that she has opted for, and we cut the tubes. For the gentlemen, we also cut tubes as well. We do a vasectomy. Nasikia Dennis
he's trying to clear his throat. It's okay. I told you to be on my side.
We also do a vasectomy where we cut the tubes, which actually bring out the sperms, as it were. Now, for the men, for this non-reversible method is sort of a big problem in this country, because the acceptance rate of a vasectomy rate is about maybe 3% or even 4%, if at best, as it were. So then we come to the other ones which are reversible, and to that, I can also add another subgroup, which is called the natural methods of contraceptions. I'll start with the so-called natural methods, and then I can come into the other group. The natural methods are the ones, for example, where a woman tracks her cycles, because during the cycle, during ovulation, a lady's basal temperature will increase by about 1 degree. So the lady in order for her to use this method, she has to track her cycle for about 3 to 6 months, such that she knows that around this date, I see an increase in temperature, that is ovulation. So if I don't want to have a baby, I will not have intercourse at that time. This is a method which is propagated by some certain areas, which is relatively a good method, so long as we are able to contain our emotions. Now, not a very good method as well, because if that patient has, for example, a common cold or some infection, of course she may have a fever. She will have a fever, and that will throw that method into disarray. The other one is following what we call the vaginal discharge. During ovulation, there is a clear, watery, slippery vaginal discharge, which physiologically is basically supposed to help the sperms to swim to get to where they are supposed to get. So if there is that watery, slippery, clear discharge, then avoid intercourse. But then, physiologically, that is a time when a woman is actually programmed to feel that she wants to have intercourse. So that can be a bit of a challenge as well. So that is a natural method which is also propagated. The other one is what we call coitus interruptus, meaning you're having intercourse, and then just before the gentleman ejaculates, he withdraws his organ and then ejaculates outside. It's like trying to stop trying to stop a train before it reaches the station, and most of the time it will reach the station and pass the station before you stop it. So it's a method which usually doesn't work. There is what we call pulse index. Pulse index is basically where we look at a number of women who have used a certain method of contraception and how many of them have got pregnant. Okay. So in these methods, for example, that one of coitus interruptus, it fails almost 90%. It fails. Sure it does. And the same with the ones where we check the vaginal, discharge and so on. So if something fails by 90%, I don't think you can call it a contraception method at all. So that is we actually don't even advocate for that. But as gynecologists, we have to put all these methods on the table so that the patient can choose the method that he or she would like. Now, when you come to the other ones now, we talk about hormonal contraception and non-hormonal contraception. In the hormonal contraception, we have quite a number of groups there. We talked about combined oral contraceptive pills. Then you have what you call mini pills. We have patches. We have vaginal rings. We have the injections that we use, and so on. We also have intrauterine contraceptive device, which is hormonal as well. And then we have another one which is non-hormonal. Then we have the ones which you have talked about, where we have condoms. We have diaphragms for the women, and we also have quote unquote condoms for women as well. We start with the condoms for women. Very few women use them because they're clumsy, number one, and by the time you get into the mood and saying ngoja wacha niingize hii kitu kwanza, and then we start the act, it really doesn't work. The condom, which is very well known and quite widely used by men, it's supposed to be available. NACOST is supposed to have these condoms actually available everywhere. For free? For free. Let's say free, because when you say free, somebody is paying for it. Right, so there should be a budgetary allocation for this. Supported, yes. Okay. But it is not available. Now, what are the consequences? You talked about they are not there. Combined oral contraceptive pills are not there. The condoms are not there. 3 months injectable. 3 months injectable are not there, and so on. I think it is a tragedy. First of all, that we as a country, how many years? 64 years after independence, that actually some of the very big programmatic things that we do, HIV, donor funded. Blood banks, donor funded. Contraception, donor funded. I was almost tempted to say dialysis, donor funded, but it's not donor funded. These are huge public health issues which we as a country should have actually taken under our wing a long time ago and run with them. What are the consequences of this withdrawal of donor funding? The donor tells you 3 years ago that in 3 years' time, we are going to do what? We'll start scaling down and we will stop doing what? We'll stop giving you this aid. But 3 years down the road, when the donor withdraws the funding, we are shocked. That ameenda na pesa yake. So what are we going to do? We start scrambling left, right, and center, looking for funds, which are meager for healthcare, but for other things, these funds are available. For political, meetings and whatever, funds are available. But for healthcare, we have a challenge. Now, when we lack contraception, what is going to happen? Number one, many things, for example, unwanted pregnancies are going to increase. There was a report by it's called African Population and Health Center, which said that in 2025, I think we had 2.8 or 2.85 million pregnancies, and about 2.4 of these were those ones it has happened. Now, something interesting. Out of those 2.85 million pregnancies, they were, if I remember well, about 793,000 induced abortions. 793,000. Yes.
In Kenya last year.
In Kenya. 2025. There's a report in 2025 and it's online. Now, something interesting. It says that 78% of those 793% were actually women who are married. Good morning.
Yeah, so what does that tell you?
Now, and I think a very big proportion, I think about 42% were women who were in the ages between 24 and 35, and then about 15% or so were about 35 years, and then comes the shocker. About 12% were actually teenagers. And we have teenage pregnancies. If I remember well, there was a report from the ministry which said that presently approximately 242,000 teenagers get pregnant annually. So all these are consequences of some of these decisions. There is no donor funding, and coming back to contraception, it says of these women, the ones who had induced abortion, 66% had access to a modern method of contraception. So there's a shortfall of about 34%, which is a big number.
Now, Dr. If we continue with those staggering figures, we might need to have a population control measures. It's funny enough that we humans appear to be the only species that copulates for fun. I don't know for the chicken, but I know humans. I don't know what scientific explanation could be behind that. But if we had an inclination to only copulate for purpose of recreation, like other species do, maybe we would not need to have this conversation about contraceptive, because it would be a natural act. Food for thought. But if you have a comment on that, I'd love to hear about it.
Yeah.
But my question is more to do with the science behind contraception. The significance of it cannot be downplayed, because again, we are humans, we behave the way we do. And some of these natural processes, unless they're interfered with, they are going to manifest, they're going to happen. You end up with an unplanned for. I mean, not say unwanted, but call them unplanned for pregnancies and the repercussions thereafter. So when we look at the science of development of contraception or contraceptives, we as an African continent, have we invested enough in research, development, and testing of the same? Because many a times we hear of various feedback, consumer reports. People will be allergic to, for example, condoms. And various contraceptions we hear, people are not, their bodies naturally are not able to adapt. So looking at that adaptability, in my opinion, it is rooted from the development of these contraceptives. So where are we in the science of developing compatible contraceptives for the African continent?
Thank you. Maybe a small correction is that the statistics that I quoted, 66% of those women who had induced abortions, illegal abortion, actually had never used any contraception. So the ones who had used were only 34%. Coming back to your question, I think that is a very important question. Why? Because most of I would say all of this, when you talk about contraception, it is the methods that we're using are actually imported. Starting from the oral contraceptive pill, which was, I think we started in the 60s, early 60s, and then we know what happened after that. Women became free, quote unquote, to engage in intercourse the way they wanted, and because they felt that now we are protected. And remember, at that time, if a woman got pregnant outside marriage, it was actually taboo. She was ostracized. But here now I'm protected. I can actually do whatever I want, and I'll still be okay. Now, all these methods have actually been brought to us. There was a method which our grandparents, maybe great-grandparents used to use, and that was more often the so-called natural method. That is why you see a grandfather has married to maybe 2 to 3 wives. If this one is expectant, he will not see her. He will visit the others, and it will be sort of rotational, as it were. That was quote unquote a natural method, even though we may not sort of qualify it as such, because we don't have any statistics, but it was sort of an inherent sort of method, I would say. Coming back to where we are in terms of research and in the African continent, I'm sad to say, and this is on record, that we are happy that we are training doctors, we are training nurses, and we are happy for them to go out there and work, because it proves that our level of training meets international standards, which I think is a misnomer, because if you are training people for other developed countries, meanwhile you're leaving your country impoverished, then I think there is a problem in the way we think, in the way we plan, and in the way we do our things. We invest for a medical doctor to go through medical school until he or she finishes. I think it's an investment of over 10 million shillings. And then we just let this person to go, just like that, to go and work in a so-called developed country. The same thing with nurses, the same thing with other cadres, and the same thing with research. We have a brain drain. We cannot be able to accommodate this. We cannot be able to create conditions for research and development such that they can sit down and actually think, what can we do in order for us to come out with certain methods, certain things which are going to be profitable for the country, and who knows, even for the world. I am involved. I was invited to a meeting, I think sometime last year, to Ethiopia. A colleague of mine, Professor Moses Obimbo, is actually spearheading a research where they're trying to find out, and this is an African-wide consortium, where they're trying to find out non-hormonal contraceptions from Africa, and most of these are from plants and so on. So it is something which is still in its early days, but I can see there's a push towards that side, so that we try and get some things which are indigenous, which are non-hormonal, but which work in the same way as the hormones. I know other countries, for example, India and a few other countries, China, they are a lot ahead of us when it comes to this. And then the other challenge that we have is that we are not serious in investing in research. We don't think that scientists are important. People who think. We don't think that people who think are important. And thinking is a difficult process, where you have to think and say, what if? and take that risk, and then be ready to actually sit down and put that idea on paper, throw it out there, sit down and make it work, and then you take it from there. We had a meeting, I think 3 weeks ago, and what you call the PPH Foundation, because we know postpartum hemorrhage, excessive bleeding after delivery, is a big problem in this country.
Right.
Our numbers are 355 out of every 100,000 women who die. Who deliver. So we lose approximately 5,000 to 6,000 women every year. So by the time we finish this meeting today in the evening, we'll have lost about 15, 16 women. 60% of these women who die are because of excessive bleeding after delivery. So we came up with an idea. Why don't we do a hackathon? And we threw this idea out there with my brother, Professor Obimbo, and we have what we call the PPH Foundation, and we had over 100 groups which were interested in coming and bringing their ideas on board. These groups were whittled down, and we got about 10 groups which took part in the first PPH conference, which has never happened on African soil, and we had it 3 weeks ago. And
here in Kenya?
Here in Kenya. You cannot believe the ideas that we got from these young people. Brilliant ideas, exceptionally brilliant ideas. But you see, we can't take all of them. We had the competition. One has to be number one, somebody has to be number two, and so on. And 3 groups actually stood out, and one of them actually won 300,000 Kenyan shillings. And what this group came out, he said, look, we can look at because we are going into the digital space. We are in the digital space, whether we like it or not. So what the group that won, came up and said, this purple book that we have for mothers, is there a way that we can integrate it into the ecosystem, the digital ecosystem that the government has actually proposed? So they said, we can take this material which is in the purple antenatal care booklet, we integrate it with the health system, such that this mother who comes, once she has been seen by a community health provider, I, as a healthcare provider, can see what has been done, can see what vaccines the babies has had, what the problems can be, how she can be referred, basically her whole history at the touch of a button. They had even a plan on how to roll this out. I was so impressed, I was blown away by the ideas that we have in this country, which we are supposed to actually nurture. But when we say that we are training and then letting them go, I think we're just cutting down, we are actually killing the inventions, the potential inventions that we have. The other idea that came up is that we use oxytocin. You talked about stockouts. KEMSA has, whatever, 8 billion shillings. And I was just wondering, if hospitals don't have medications for dialysis, medications for cancer, medications for postpartum hemorrhage. The other day I was in a hospital and we did not have medications for high blood pressure in patients who had delivered what we call preeclampsia, and they need to have it. It was not available.
The hospital didn't have them.
It was not available. So I asked my junior colleagues, what we call residents, I said, but so what are we doing? They said, no, we are writing prescriptions for these patients. And they,
for them to go and buy.
For them to go and buy. It's not right. It is not right. It is not fair. So when you are talking about the stockouts, stockouts of contraception, sometimes contraception may not be an emergency.
It sometimes seems it's almost like a luxury.
Yes, quote unquote, because if you can withhold that a bit, you may, that moment may pass. But if you have a crisis, high blood pressure, 270 over 130 or whatever it is, you need that IV medication and it is not available. So I was just thinking, if you're talking about stockouts of these medications, Sembuse. Is that a nice way? Sembuse, you know this. So yes, we can talk about stockouts of contraception, which is a crisis, but we have other bigger crises which are actually brewing.
Look, this speaks to a plan that a country should have, a plan that policy should then get to inform everything you talk about in terms of budgetary allocation.
Correct.
Because when you talk about unavailability of contraceptive in the country, it's because we've looked at the donors to do that, they've left, and we are shocked because we never put in contingency measures to take care of our business.
Correct.
Because our business has been taken care of by those who are outside.
Correct.
But beyond that, you look at the bigger picture. So we do not have contraceptives. There is a problem when it comes to STDs, STIs that would be there. That is a disease burden to a country that is not prepared. You look at the population pressure that would come where contraception is not there as well. And the government needs to plan and budget for that. Are we having these discussions? Rather, does the government look at it from a perspective of pressures that would come if they do not put measures to deal with contraceptive use and what is needed in the country?
I'm sure my colleagues at the Ministry of Health have been having these discussions, and I'm sure in collaboration with technical colleagues in Treasury, and so on. I'm sure when they do their budgetary allocations, they say we need X amount of money for this, and so on. The policies that we have are beautiful. But do we always follow through with them? No. Other countries come and borrow our policies, and then we go and do benchmarking in their countries, which is not right. Coming back again to the stockouts, I think last year's report, which said I think there were new HIV cases, I think over 20,000.
Yes.
Over 20,000 HIV new cases, and women were unproportionally, represented in this. I think over 13,000 of these. This is also something about lack of contraception, lack of condoms, because we know that if you're going to use condoms, there is a high likelihood that it protects you from HIV, it protects you from herpes, it will protect you from syphilis, and so on and so forth. You talked about gonorrhea, that is going to be there, and is going to be, and we're even not talking about drug-resistant, strains of gonorrhea, and so on. So lack of this is a challenge. Now, we talk about, this is the budget, this is what we are going to do, this is the allocation, but most of the time we actually don't follow through. Now, and that is at the national level. At the county levels, I think it's the same issue, only again a little bit on a wider scale. Money comes from the national government, goes to the county governments. There is no, I stand to be corrected, there is no money that is ring-fenced, that this is actually money which you will not touch, and this is for health. It goes into one basket, and from there, that is where we do our development, that is where we do our salaries, that is where we do everything, and so on and so on. So when a crisis comes, there is no money. It has gone to all manner of different things.
Right.
And then something interesting is that as politicians want to show things they have done. I have built, I've roads, I've constructed roads, I have built this and that, things which Mwananchi can see and say, actually, Dennis has actually done this and this. Health is intangible.
You don't really get like the accolades.
That mother you say is actually not seen.
Yeah.
So even if you say, I have helped X number of
prevented sexual disease,
but we don't see that. We don't see that. Not knowing that further down the road, this public health initiative is actually going to bear a lot of fruit. For example, it is well known that if you're going to invest $1 in maternal care, it will reap 10 or so many dollars down the road. So then why don't we do that? Because it is not tangible. I cannot put my fingers and say I invested $1 and then 3, 4 years, 5 years down the road we have reaped $10.
But I can see a ramp on a highway, for example.
You can see a ramp, you can see a road which leads to my residence, and so on.
Well, it is true. We lean more towards those popular initiatives. And unfortunately, we leave what we need most for human development, because I think that's something we have continuously neglected, developing the humans of the country. Now, I compare Kenya with other countries, and sometimes we just keep on comparing ourselves with the West and Europe. But today I want to compare our health system with that of Cuba. Cuba runs, in my opinion, a very high quality, highly easily accessible healthcare system.
Correct.
Here we talk of community health promoters. Then they talk of community-based family doctor. The way you're talking of tracing, that you're able to trace, illnesses, development, and all that.
Yes.
What will it take, in your opinion, because you're in the healthcare ecosystem, for us to prioritize healthcare and realize the economic impact it has, the social impact it has, the political, it affects everything, even the level and quality of education.
Correct.
You spoke of brain drain. If things were working in Kenya, people would not need to travel far. We would be able to regenerate and rejuvenate ourselves into newness. What will it take for us to understand that neglecting public health actually is a threat to our internal security? What will it take for us to move from where we are today and stop politicizing projects, stop politicizing events, stop politicizing budgets, and focus? Because like right now you look, I think health was given 177 billion. But how much of that goes to research? How much that goes to specialized care? Even facilities that are at the national level that get direct budgetary allocation, you look at how they are managed, it's very wanting. What will it take, or what do we need to do now as a people? And create the change that we so much deserve?
I think that is a suicide question you've asked me, but it's okay. I'll try.
From a professional point of view.
I'll try and tackle it from a professional angle.
Yeah.
The Constitution says we, the people, we have actually delegated this power to whoever it is there.
Yes.
So we, the people, can actually do what? Get that power back. But we have to realize that we have this power, number one. Now, what will it take for us to have a similar sort of system like Cuba? Remember, Cuba has been demonized. Look at the sanctions that have been in place for over 40 years, 50 years. And it is still standing. It has actually exported doctors to other countries,
even
to
Kenya,
Latin America. The ones to Kenya, I will take you with a chicken tongue. But be it as it may, its public health system is actually, albeit all these things, all these problems that it has encountered, it is structured and helping the people. I trained in a communist country, and I saw what they had planned and what they had. They had nurses in schools. They had dental technicians in schools. They had doctors, in all the halls of residence. So if you had a problem, you didn't have to go straight to a hospital. You'd go to the doctor who is allocated to that particular place. What would it need for us to change this? I think, number one, the day the government or we the people will decide that anybody who is sick, irrespective of position, will go to a public hospital. That will be step number one. Number one, the money will flow to the public institutions, and with the money will come technology, and with the technology will come research, and so on. The day we decide that you as MCA, you as an MP, you as a county governor, your place is to go to Kenyatta National Hospital, to go to Makueni County Hospital, or whatever it is. That is the day we'll see a huge fundamental shift. There'll be more money allocated to health than what is allocated now. Number one. Number two, we have to change the way we train and who we train, and the scopes of practice have to be very clear. Just like I mentioned, in Cuba you have a family doctor right at the bottom there, mashinani kule. So instead of recruiting community health providers, and we think that we are doing something, I think we are just not serious. Who is a community health provider? With all due respect, good morning, with all due respect. Yes. These are guys who for lack of something else to do, they have been given something to do. And we give them a tablet, and then we tell them this is the way unapima pressure and whatever, but not knowing what implications are there. Some of them have been trained, but even the training itself is lacking. Let me limit myself to maternal health.
Right.
These are people who are supposed to sort of have an idea. If an expectant mother has this, please do this, send them. They had, I think, 1 week's training. And when you look at the curriculum, it's really, really wanting. Really, really wanting. But it's a stepping stone. We can increase their little bit of knowledge such that they are more aware about what they're supposed to do. But the question of the structure that we have this doctor here, the way we have Nyumba Kumi now, even though it's not very well pronounced, in some countries, like for example Rwanda, it's very, very clear. Whether you're in the city, whether you are in the village, there is a Nyumba Kumi. So that structure can actually help. So we know this Nyumba Kumi, we have 100 households, they have a nurse or they have a doctor there who is actually taking care of them. Once we put that structure in place, then we can talk about actually accessibility, availability, and affordability. As it is now, we can't talk about that.
Quickly, as you come to the top of the hour, how should one, ladies, decide how to get the best contraceptive? Because do I go for what my aunt uses, my mom uses? What is the best way to go about it?
Or over the counter.
Over the counter, OTC, yes.
First of all, over the counter is the worst mistake. We should never go for contraception over the counter or any medications for that matter. But Kenyans, we are like that. Unaenda mnasema mimi nasikia hivi nipatie paracetamol, niko na malaria, awe uko na malaria, and then you are given something for contraception, for example. So I think the fundamental thing, because contraceptions are going to affect your life. For example, if you decide to use hormones, they will affect the way your body behaves. Go for advice, go to your doctor, and if you have a gynecologist, please go to a gynecologist, because this is the remit of gynecologists.
Indeed. Dr. Kireki Omanwa is the president of the Kenya Obstetrical Gynecological Society. He has been here with us this morning. We've talked about layered issues here, about what you can do in terms of practice, but then also what the global issue is and global mean overall in the country at the moment. The hope is that there won't be stockouts. The hope is that there won't be lack, but that we should also be aware of what it is that we're dealing with. Thank you.
Our dreams are valid.
Indeed, they are. Thank you, everybody, for being in the Situation Room.
This is the Situation Room, the only way to start your day.